Yeah, first of all, I would like to thank the organizers for accepting our presentation. I'm not sure I will be able to finish it in 2 minutes, but I will do my best. These are my disclosures. Hungary is a small country. Hungary has 10 million inhabitants and 7 cardiac centers where they're performing cardiac surgery, and among them only Semmelweis University is doing heart transplantation. You can see the numbers, the increasing numbers over the last 25 years, but over the last 5 years, after joining the Eurotransplant network in 2012, our numbers of transplantation, which are the red boxes, are tripled or quadrupled. First of all, the facts behind these numbers are better coordination due to the Eurotransplant network and high urgent listings of the Eurotransplant. Of course, we also introduced extended donor and recipient criteria, as well as we have utilized the MCS strategy, what we didn't have before. Our outcome numbers are improving. Of course, in 2010 it was a mere 50%, and we are not very proud of that. And if you look at the last 25 years, splitting in decades, the third decade of cardiac transplantation in Hungary is doing gradually better and better, but we are still far from the 90% survival after 1 year. We are about 80% at the moment. Not only transplant numbers increase, but as you can see on the blue bars, we introduced our ECMO and mechanical circulatory support program as well. We have good numbers on ECMO, and our results are acceptable. Most of our patients survive, the first 80% survive after 1 week, but of course after 1 week the survival curves are kind of split, and no one survives 2 weeks on ECMO. Of course, the ECMO and ECMO is different. If you compare patients' indications for therapy, we have good results on intermax patients and post-cardiotomy patients. Even on post-transplant primary graft failure patients, but our results are quite limited in acute MI, where we are implanting the ECMO in the cath lab. We are really proud of our LVAD strategy and our LVAD outcomes. The first HeartMate 2 was implanted in 2012, September, and since 2015 we changed to the HeartMate 3 device. We haven't lost any of our patients in the perioperative period. 18 patients are still ongoing. We transplanted 7 of our patients, and we have only 4 deaths during this time. Unfortunately, 3 of these deaths occurred during transplantation, so we are really at the beginning of the learning curve, transplanting patients from LVAD. I know this slide is kind of shaky, but based on our very limited experience, we do have some survival benefit on LVAD compared to cardiac transplantation. Of course, we have a lot of challenges in front of us. First of all, as you see, the patient numbers getting on the waiting list year by year, which are the yellow bars and the green bars, and the red ones being transplanted, the blue ones being the numbers of LVADs, and the grays are the losses and deaths on the waiting list, and the R status is the pink one. So you see we have about equal numbers, which means we are transplanting everybody more or less who is getting on the waiting list. This is not a healthy number, so the listing numbers are quite limited, and we should encourage cardiologists to refer heart failure patients for the waiting list. And of course, we have to review the R status and patient death on the waiting list. Of course, our early referral for mechanical circulatory support and LVAD would increase our, for example, these 2 patient groups would increase our numbers and maybe the outcomes. And of course, we are still planning to introduce a mobile ECMO unit to transfer patients from the countryside to the main center at the Semmelweis. Thank you very much. This is what I would like to thank you.
Thank you very much for a very important presentation and your fast-track presentation. No one kicked us out of the room yet, so it's open for questions. What is your policy at the moment between directly heart transplant and LVAD as a bridge? What is the decision?
According to the Hungarian system, only those patients can get an LVAD who is actually transplantable and on the waiting list for transplantation. And of course, it's a kind of soft indication, we all play with it, but this is the basic rule. And usually, as we have kind of favor for transplantation, and because of our patients who are in really big trouble, can get on the high urgent list of the Europe transplant system. And on the high urgent list, about 80% of our patients are getting a heart within 2 weeks. So we are quite in favor for transplantation.
Okay, and last question, emergency patient, you put them on ECMO,
yes.
Then LVAD, and then maybe, what are the results of this cohort?
We are on the learning curve. Honestly, we are just about our first patient who was going through this course is just 2 months old. So he was an urgent patient with ongoing ventricular arrhythmias, and we put him on ECMO. And after 2 days, we upgraded him on an LVAD, and he's luckily doing well. But he's actually the first one in the last 2 months.
Okay, thank you very much.
Thank you.
Please conclude our talk. I thank you very much, and Professor Zila, for this very nice joint session. And I think the next one will be in November in Johannesburg or Cape Town? Johannesburg. So I hope everybody will come. Thank you very much.